Okay, welcome everyone. We're so excited to have you here today. Thank you for coming. For those of you who are joining us live, um, I'm Wendy Singer, and I am Executive Director for No Shame on You, which is a wonderful nonprofit that is based in out of Chicago, but all of our virtual programming allows us to have a natural reach. So thank you for coming from wherever you are. On behalf of our board of directors, staff, and volunteers, I warmly welcome you to today's program. No Shame on You is dedicated to reshaping attitudes about mental health, elevating conversations, and disarming stigma. We support young people as well as those who support them with tools to understand, talk about, and respond to mental health challenges. We fulfill our mission through comprehensive outreach programs, customized mental health workshops, team programs, tons of free resources on our resource library, and a robust online presence with over 120,000 social media followers. So if you haven't yet checked us out on Facebook, YouTube, LinkedIn, and Instagram. We partner with organizations and experts throughout the Chicagoland area and across the country, and are recognized for our inclusive, consistent, and responsive programming for all backgrounds. I do want to express gratitude to our incredible sponsors displayed in the pre-roll slideshow that you saw that helped make this programming possible. Before I introduce the speaker, we will hold a short Q&A at the conclusion of the program. You can submit your questions directly to me, Wendy Singer, who is the host, and we will address as many questions as time permits. And if something comes up in the middle, we can even stop and ask a question. It's now my pleasure to introduce a special man, today's speaker, Ira Finkel. Ira received his bachelor's degree in social work from Northeastern Illinois University and his master's in clinical social work from Rutgers. He then returned back to Chicago to earn a certification as a school social worker through Loyola University, Chicago. Ira is endorsed by the National Association of Social Workers as a school social work specialist. Ira has worked across academic settings that include private, charter, and public schools where he evaluated, wrote, and implemented individual education plans, IEPs, and 504 plans for students. And he utilizes his experience and training to support and advocate for students in school. Ira is currently as I said, a
Which
licensed
is
social
fine
worker.
because 6 weeks is the last week of March or
I'm going
last
to
week of
ask
May.
everyone to please turn off their
So timing
microphone.
wise, it's not horrible. Yeah,
Hang on one second.
yeah, it's
If
good.
everyone could
Yeah,
mute, that would be fabulous.
it sure does. Yeah.
Hold on, I'm going to take care of that. There we go. Thank you, guys. All right, wonderful. Um, So I lost my page, but I also want to say that Ira is the owner of Anxiety Professionals of Illinois, a private practice. And just another little bit of side information. I've known Ira a long time. In my previous career, I was a longtime summer camp director, and ages ago, Ira was on our team as a camp counselor and one of the best. And he currently serves as a member of the No Shame on You Advisory Committee, where we have professionals from all different walks of life around mental health and youth and all those things. And we're so grateful that he volunteers his time to help us and help us with our materials and advise us. And without further ado, take it away, Ira.
All right, thank you, Wendy, and thank you for the overly generous introduction. Um, so we're going to talk about body-focused repetitive behaviors, and this includes a lot of different categories. Um, so first, what are body-focused repetitive behaviors? Body-focused repetitive behaviors, they are a recurrent self-directed behavior that causes either tissue damage or it can also cause sorry here, functional impairment as well as occupational impairment. BFRBs such as skin picking, which is about 3.5% of the population, and hair pulling is about 1.7% of the population. They affect a total of 15 to 25% experiencing some subclinical symptoms, which means that they're not quite getting to the point where they're needing, some additional treatment. Um, they're very common, but also highly distressing, and they can also be very embarrassing, which is one of the barriers to people seeking treatment for these. So, starting off, how do they feel? Most individuals, they start off with feeling this urge to engage in the picking or the pulling. Then they have a tension where it becomes almost unbearable for them to not do the picking. They then engage in the picking, and that provides them with some relief. These behaviors can sometimes be conscious or automatic. And what I mean by that is sometimes people are aware of them, but sometimes they're not aware that they're engaging in these behaviors. Stress, anxiety often exacerbate these symptoms. So, common types. Now, most people are aware of trichotillomania. That's kind of the stereotypical one that people think of. And that is when people are pulling the hairs, usually from what people think is just on their head. However, this is not limited to just the top of our head. Some of the other common areas that I've seen are eyelashes, eyebrows, facial hair, and nose hair. Next, we have skin picking, also known as excoriation. This entails repetitive skin manipulation that's causing some lesions, scarring, can also lead to some infection risk. And when they're bad enough, this can actually lead to where medical intervention is needed to avoid amputation of limbs. Management for this emphasizes a harm reduction model. And harm reduction means that we're trying to get it to a point where it's causing the least amount of damage. Next, we have nail biting and chewing. So this can cause significant infection as well, both in the mouth and in the areas where the nail biting or the chewing is occurring. This can cause some dental issues as well, as it can cause lesions within the mouth, impact their teeth, as well as functional impairment. And when we're talking about functional impairment, imagine that you've got to write or type things, but you have picked or chewed at your nails to the point where it is causing infection. Um, Other types that are a little bit less common is nail picking, cheek biting, skin biting, eating of our hair, biting our lips, jaw grinding, as well as nose picking. So what are the causes and triggers for this? So genetic predispositions and neurobiological differences influence the impulse control and the habit consolidation. When when we're thinking of this, we want to assess a family history and any comorbid neurodevelopmental or psychiatric conditions that can inform our treatment planning. Now, research suggests that OCD and BFRBs share a genetic risk factor, meaning that if somebody in your family has one of these conditions, you're more likely to develop it. Within the DSM-5, BFRBs are actually categorized within the overarching obsessive-compulsive disorder behaviors. Around 17 to 18% of people with BFRBs will have a family member that has OCD, and this is higher than that in the general population, suggesting that OCD and BFRBs can run in families. So stress and emotion can certainly be a big piece of these BFRBs. Things such as like anxiety, boredom, frustration, anger, these often precipitate the BFRBs and the BFRBs become a maladaptive coping mechanism. We want to intervene by targeting the emotion regulation and the stress reduction to help decrease the reliance on these behaviors as a means of coping with our emotions and stress. There are also environmental cues that impact BFRBs. So specific contexts such as, when we're looking at screens, when we're in front of a mirror, when we're in solitary settings, those can certainly increase the likelihood of a BFRB, as well as tactile and visual triggers that prompt the automatic behaviors. And so we want to modify the environment that we're in order to help reduce the frequency of these BFRBs. Now, when we think of intentional or conscious, that's when it's done purposely engaging in these BFRBs. So like I said, when we're looking in a mirror, picking at our acne to smooth skin, or pulling hairs that just don't feel right. Um, they can also be emotionally driven, like I said, as a response to stress, anxiety, negative thoughts, or emotions, or in an attempt to get rid of the unpleasant urge or memories. It is also very common for pullers and pickers to pick or pull out of awareness. This is what we would consider unconscious or sometimes mindless. For example, when we're studying, when we're reading a book, talking on the phone to people, sitting at a desk, or on our computer. Now, most individuals with BFRBs, they will engage in one of these pulling styles at one time or another.
Okay. My parents put in pool.
So support and treatment. So when do we want to start seeking help for this? We want to pursue an assessment when the behaviors cause medical harm, social or occupational impairment, or cause significant psychological distress. As I had mentioned earlier, sometimes these BFRBs can get to a point where it's causing infection, and we're concerned about things such as gangrene, death of tissue, as well as, when it comes to things that involve our mouth, when it's impacting our ability to just take in nutrition. Now, when we think of the therapy models for BFRBs, we have three evidence-based models. We have acceptance and commitment therapy, also known as ACT. This was developed in the 80s, and it teaches you to observe and tolerate the urges as internal experiences that don't need to be acted upon. Then we have something called habit reversal training. This was developed in the 70s, and this teaches and encourages awareness of the early warning signs that occur before picking and engaging in a behavior that is incompatible with BFRBs. Now, what do I mean by, engaging in a behavior that is incompatible with BFRBs? So when we think of if people are engaging in nail biting or pulling of their hair, when they start to get that urge to do it, what we call a premonitory urge, we're going to encourage them to do things such as sitting on their hands or putting their hands in their pockets or using a fidget until that urge goes away. We also have comprehensive behavioral treatment, also known as COMB. This was developed more recently in 2013 and is a more holistic approach that utilizes both habit reversal training and behavioral analysis to identify the need that the BFRB addresses across 5 different settings, which are sensory, cognitive, affect, motor, and place. Now, when we think of sensory, we're talking about the physical urge or sensation or the need for a specific tactile stimulation. When we think of cognitive, we're talking about, the unhelpful thoughts, beliefs, or mental rules that precede the behaviors. Affect, we're talking about emotions and feelings such as, like I said, boredom, anxiety, stress, frustration, or even excitement. Motor is going to target the physical automatic actions of the behavior and develops that competing response. And I'll get into some more of the competing responses in the next slide when we're looking at self-help strategies. The last part is place, and this is where we're trying to modify or intervene the place where these picking behaviors occur. Oftentimes, these can occur in the bathroom when there's highlighting and the mirrors so we're able to inspect more, as well as when people are not in the presence of other people. That's when it can be, in their mind, a more acceptable and less stigmatizing time to engage in these behaviors. When we think of medications, so as far as medication for BFRBs, there's actually no FDA approved medication for this. But there is some evidence that N-acetylcysteine, or NAC, and memantine are effective interventions, with both causing about 50 to 60% of people to have much or very much improvement with their BFRBs. The ones with some compelling evidence that did not show statistically significant differences in outcomes in the general population were naloxone and lamotrigine. Dr. John Grant is a psychiatrist from University of Chicago, and he's the one who does most of the BFRB medication research. When he did subtyping analysis na- on naltrexone, he found that it was actually more likely to be effective if the person had a family history of alcohol use disorder. For lamotrigine, it was found to be more effective for patients who demonstrated cognitive inflexibility. When we think of cognitive inflexibility, we're thinking of, black and white thinking, um, rigid thinking, or a neurotic personality structure. So when we think of self-help strategies, these are things that, the individual who has the BFRBs can implement on their own. Now, Keen 2 is very different from, some of these other strategies in that it is a wearable device, much like a Fitbit, and it can be programmed to help build the awareness of the BFRB behaviors. Like I said, sometimes, these are happening unconsciously and without awareness of the individual. And so the Keen 2 gets programmed that when the individual is engaging in a behavior with their hand that is very much consistent with what they usually do when they engage in this BFRB, it is going to vibrate. And that helps to build their awareness. When we think of, for nail biting or picking at our nails, cuticle oils can be very helpful for that because it will help to soften the tissue that is around the base of the nail. That way we're not having a lot of dried areas that are, more prone to be like prickly and more susceptible to being picked. We can also use bandages. Now, bandages can be used in a variety of ways. They can be put directly on the fingers. So for instance, if somebody tends to engage in the picking with their thumb and I think this is the index finger. If they're engaging in the picking with those, we can put a bandage over the top of those fingers because that's going to prevent them from being able to get a good grip on either the hairs or prevent their nails from being able to actually scratch. We can also use finger cots. Now, finger cots, for those who are not familiar with it, I always find it, funny because I kind of think of them as almost like finger condoms because they do look a lot like a condom. And there's something that you can get at a drugstore, pharmacy, your local grocery store, and there's something that you roll over your finger. Um, the one problem with these is that they can sometimes be more visible to other people. When we think biting of our lip or picking of our lips, we want to use things like lip balm. For me, I tend to be somebody who, when my lips are dry or cracked, that's uncomfortable for me. I don't like the look of it. I don't like how it feels. And so I'm going to be more prone to pick at that time. And so I'll use lip balm on a nightly basis to help prevent my lips from being cracked or dry. We can also look at hair products. So hair products can be not just ones for the hair on the top of our head, but also hair in other parts of our body. So a common thing that I like to suggest to people is using Vaseline. The reason for the Vaseline is one, it is going to help with our awareness because we're going to feel the Vaseline. But it's also going to help lock in moisture, and that's going to help with dryness um, for skin, and then it can actually help us to manipulate our eyebrows in a way that's going to make them look the way that we want to, so that we don't have to pick them. Another common one for eyelashes, that would be like mascara. Putting that on this way, when you start to go to pick an eyelash, you're going to see and feel the mascara on your fingers. One that I like to actually use because I also tend to, when I'm bored or stressed about something, I am prone to trying to pick at my beard, which is a disgusting look and can actually be hurtful, like if I'm pulling a hair out of my beard. And so something that people can do for that is use beard oils, beard balms, um, beard washes at night to help with any itchiness that could be underneath. We also want to consider like other barriers. So things such as, like I said, sitting on our hands, putting our hands in our pockets, having fidgets. These are all things that are going to help with the barriers. So when we're building a support plan for either ourselves or individuals with the BFRBs, we want to develop one that identifies the triggers, the specific replacement behaviors or competing responses that we're going to use, clear emergency steps, and up-to-date clinician contact information. When you're working with a loved one who has BFRBs, one of the things that's very important is the compassion piece, because a BFRB, like I said, it can seem very disgusting to people. And there's a lot of stigma with it. And oftentimes, as parents, we tell our kids, oh, just stop biting your nails, stop picking at your fingers. And as I'm sure a lot of you have probably seen, that's not going to be very effective. If it was just a matter of willpower alone, then we wouldn't be dealing with a BFRB. So we want to have a trusted support person who can help build the accountability so that they're not just relying on themselves, but having somebody there who can help them keep track, help give praise when they're doing well with it, point out when they see the BFRB that might be unconscious to the individual. We also want to set measurable goals. So when I talk about measurable goals with BFRBs and with the category of OCD as a whole, we're not looking to completely get rid of it. We're looking to get it to a point, um, almost like with cancer in remission. We want to get to be in remission, not be impacting our life as much. There's going to be times when we're more stressed where, that can pop back up. And it's important to have your plan in place. This way, you're not relapsing into a BFRB that is causing a lot of functional or medical or occupational impairment. Um, we also want to schedule regular progress checkpoints with a clinician or with a therapist or with a family member to ensure ongoing adherence. So in conclusion, BFRBs arise from both biological, emotional, and environmental factors that are causing significant harm. A combined approach of self-help, behavioral therapy, and clinical care optimizes the outcomes and reduces the complications. Some of the resources that are very helpful online, there is BFRB Changemakers, trickstop.com, the TLC Foundation for Body Focused Repetitive Behaviors, Picking Me, and then the International OCD Foundation. There are also a lot of really great self-help books that I've used with both clients and with family members. So Free to Be Me with a BFRB is geared more towards the younger population. Overcoming Body Focus Repetitive Behaviors is a guidebook that outlines that comb model so that you can kind of help yourself. The BFRB workbook for teens and young adults is very helpful, as well as the BFRB survival guide. Now, when we think of therapists, we want to explore therapists that actually have training in these areas. Even though BFRBs do fall under that overall category of OCD, they're not going to be treated in the same way that OCD is. So we really want to ensure that we're finding therapists who are well trained in these areas. Um, Local to Chicago, there is one of my favorite therapists to collaborate with on this is Lisa Conway. She is the owner of Exposure Therapy Chicago. Um, there's also a self-plug here of Anxiety Professionals of Illinois, which is my practice, where, obviously I'm trained in how to address these BFRBs. Now, when we also think of, going back to that medication piece, Curious Mind Psychiatry, Dr. Jacob Cross, he was actually trained at Yale and specializes in BFRBs and OCD as well. All right, so we're going to move on to, I guess, Wendy, if there's questions or the Q&A period.
Thank you so much. If you have questions, we did get some that did come into me that I will ask. And if you
Okay.
have more, please keep sending them. So can you, when one question that came in is like, is there ever a point where you shouldn't seek help? Like when it's not something, like it's something that is happening to a loved one or yourself? Um, like what is the point that it becomes something that you should seek help with?
Well, we definitely don't want to be encouraging people to seek help if they're not open to it. And that's a common thing within therapy as a whole. If we're trying to force an individual into therapy and they're not wanting to do therapy, the likelihood of buy-in and progress within therapy is not going to be high at all. Um, as I said before, when it's a little bit on the, functional or occupational impairment, or when there's, medical complications, that's really when we would want to seek help, or if it's just causing, psychological stress for the individual.
Yes, thank you. Um, I'm going to share a little bit of my own story because I have a curiosity question. So at 15, I started picking skin on my feet. And I was mortified and embarrassed, and I would not do it when I would go to summer camp because it was the social pressure. And I wouldn't, you know, I would wear socks and shoes so no one could see it until it healed and all those things. And then a very interesting thing happened, Ira. It lasted the two times that I was pregnant during my life, the urge completely went away. Okay. And now I am 49 years old, and about 4 years ago, it started to go, it completely reduced. So I wonder, is there any kind of connection to like hormones, or is there any research on that? Because that was something that like blew my mind away.
So I have not encountered any research when it comes to hormones with it, but a common thing when it comes to BFRBs, and Wendy, I really appreciate you sharing that with your feet because actually my mother also, she would pick at calluses on her feet.
Yes.
And so a lot of times can get to a point where there's just so much damage that it's creating, like I said, prickly points, places that we can visibly see need that repair. And sometimes we just need to have like a reset for that. So things such as like going for a pedicure, or having a pumice stone to help, shave down the calluses. Like I said, putting moisturizer on other parts of our body to help soften the skin. Those can be really great ways to help have a reset and allow us to not be as distressed and not see visual signs that say, hey, come pick me.
Yes. And I agree with you. For me, I would buy this hand and foot cream, and in the winter when you're dry and it was like night and day when I would try to like regularly moisturize. So I appreciate that advice. And for me, that did help. Another question that came in is, first off, thank you for all the incredible resources. We will be sharing the slides with anyone who attended, so you'll get a list of all those resources. Do you have any suggested resources by chance specific to cheek biting inside your mouth?
Yeah. So for cheek biting, we want to talk about like the competing response of actually having something else in our mouth to help prevent that. So thinking of things such as gum or, sucking candies. Those are things that are, we're going to be able to divert our attention instead of our cheek. We've got something else in our mouth that we can bite on.
Thank you. Um, we got a couple questions about this, so I'm going to lump them together. The question was, is there a specific age group in which this type of behavior is more prevalent? And can you speak to the differences between kids and adults if there are any?
Yeah. So oftentimes there is a uh, developmentally appropriate time for BFRBs where it's not something that we need to address. So when we're thinking of, infants, they tend to just grab at their head, grab their hair. Those are not things that we would consider BFRBs. Those are all developmentally appropriate and as part of, a child's exploration of their body. Um, as I was talking about with Wendy before we started, I have a 5-month-old and, he's going and he's grabbing at his feet, scratching at his face, pulling at his hair. Those are all things, though, that are developmentally appropriate.
Thank you.
From what I've seen is that BFRBs they tend to start earlier on in life. When we're thinking, you know, teenagers especially, it's a very stressful time. It's when we've got acne going on. Nobody likes to be dealing with acne and, the what teenagers often think is the world paying attention to them. So they want to get rid of the acne that way nobody's judging them. Um, certainly I think we all know that, as a teenager, the whole world's not looking at you because they're focused on is the whole world looking at me?
Exactly. Okay, so I have a couple more questions. Wondering how to handle it when someone has a sensory processing disorder and can't tolerate things like chapsticks, band-aids, bandages, Vaseline, and the such.
Yeah. So that it's a little bit of a trial and error process. Sometimes, especially when we think of, the top of our head being a place where we pick, we can do things where like we're wearing a hat, we're wearing, a hood. Those are things that are, serve as barriers again to being able to pick. It makes it harder to go and pick. If you're wearing a hat, you got to take the hat off in order to pick. So putting barriers like that, but it is unfortunately, it is a lot of trial and error with that.
I'm sure. Okay, the next question is, which I think is an important one. What advice would you give to parents if you have a teenager who's a picker and they're not interested in therapy, they're not there yet, but it's hard for you as a parent to see the debris, nail, skin, that type of thing. What do you recommend for us as parents on how to stay calm and what to do?
Yeah.
Keeping it real, Ira.
Yeah. So we want to work with our teenagers or our kids to find ways where it's not going to be as visible to us as parents. So whether that's, having a garbage can right there in the bathroom that is specifically for when they want to, them putting their nails in there, or having them keep with them like a little bag sometimes where, okay, if they bite their nail off, put it in the bag, then you can throw it into the garbage later.
That's a great idea. That is a great idea. Well, we got to all the questions. So thank you so much. If anyone, because we have a little bit of time, before you hang up, if anyone wants to hang out in the virtual lobby, as I call it, and ask a question, you are welcome to do so. For a few minutes, we'll do that. I am putting in the chat a survey that oop, I sent it just to one person. Give me one moment. But we have a short survey. It literally takes a minute to fill out, and it helps us make sure that we are hitting the mark and report back to our funders and all those things. Would love your feedback if you have time. Um, okay, and one final question came in. Isn't it important to figure out what underlies the anxiety? What are your thoughts on that?
Yeah, and so that's where we kind of go back to that SCAMP model where we're looking at the affect. And so treating the underlying anxiety can often, you know, make our our need for this coping mechanism to diminish. So most of the time that I'm working with individuals with BFRBs, there is some, co-occurring or comorbid diagnosis of an anxiety disorder or OCD. And so by treating those, we can decrease the likelihood of them needing to use these really maladaptive coping skills, and also teaching them, other coping skills. We also want to think of sometimes what we call distress tolerance, which is, there's going to be uncomfortable feelings and just tolerating that discomfort, and not engaging in, this behavior that gets rid of that discomfort.
Thank you, Ira. All right. Well, I'm just going to close out with thanking everyone for coming today. If you are local to the Chicagoland area, we have this awesome event coming up. It's May Mental Health Awareness Event month. And in Skokie, Illinois, is an incredible coffee shop that I love. And I work out of it at least once a week. No shame on that. And we have our incredible team board who is gathering leading some activities and resources and all the like fidget making activities and planting and different mental health activities. It's meeting like-minded teens. We have some cool teen musicians who are doing some playing of things, and it's open to teens and also those who love them, which are many people in this Zoom room. So if you're bored, come on by. Also, if you're local to Chicago, they're doing a roundup the entire month to support our programming. And there's an amazing cafe next door called Zelda's, where 5%, Zelda's Table, which is doing a 5% back to No Shame on You this month. We're so grateful for partners that help us with those things. So thank you, everyone. Have a wonderful rest of the day. Our next Feed Your Mind is we're taking a break until September because it's summer and a lot of people are traveling and are spending outside. So stay tuned, but do follow us if you don't already. We have an incredible blog series right now on lesser known pieces of OCD, including some of the things that Ira talked about today, and another really interesting topic that we're sharing right now on scrupulosity, which is a faith-based OCD, um, um, lesser known disorder. So it's really fascinating. So check it out, join our mail list, and we will see everyone soon.
And Wendy, before we step out, I'm actually going to
Yeah.
put into the chat because I know, like I said, um, it can be very embarrassing with these BFRBs. So if anybody has questions that they're just not comfortable with in this setting, I'm going to put my email down here in the chat. This way, feel free to email me. I'm more than happy to answer any questions. I do see from Pamela, she wants to know the list of the medications. So let me go ahead
Thank you. I
and
missed
take,
that one.
sure.
We're a good tag teamer, Ira.
Let me go in here and I can grab that.
Well, thanks everyone. this concludes the formal portion of our program, but we will hang on for a few minutes if anyone wants to chat for a moment. And we'll see everyone soon. Take care.